Brain tumors simply means new growth in the brain.
How does one know a person has brain tumor? What are the symptoms that present initially?
In management of brain tumors, early presentation is key. Unfortunately, some of the symptoms of brain tumors can be mimicked by so many other things. So it makes it difficult for you not to continue treating malaria recurrently when
it's actually brain tumor.
Yeah, when it's actually brain tumor. For people that have malaria, they tend to have headaches. Headaches come on more in the morning. Patient can give a severity scale of about 8 or 9 over 10. But with time and with activity during the day, the headache tends to come down. But very early in the morning, when you think you have rested well from your sleep, then you are waking up with a very terrible headache. Then you need to see a specialist. I've had patients before that the reason why they had come to hospital to see me and we made a diagnosis of brain tumor was because she was recurrently burning the husband's food.
Are brain tumors age-related?
Brain tumor can occur in all ages. I've seen a child that is less than 1 year with brain tumor, and I've seen a 20-something-year-old patient with brain tumor.
What are some of the myths that you have to daily correct when you see your patients who come in for brain tumor related?
It's an arrow. It's a family arrow. It is somebody that does not like me in my village that sent it to me. Brain tumor diagnosis is not a pleasant news.
Hey everyone, wherever you're watching and listening, welcome to another series of Health Conversation with Dukes, an educative and interactive podcast section set up to learn, unlearn, relearn about health topics, health-related issues within and outside our world. Today promises to be another very interesting episode, just as you've watched in previous episodes. Please sit back, relax, listen, ready to learn. Pick up your pens, pick up your biros, pick up your books. You need to jot down a whole lot, as we promise today's discussion promises to be a wonderful one. Once again, my name is Ayorinde. I will be one of your hosts. Together with me on today's episode, I have my colleague and a friend.
My name is Mr. David Ahiwe, and on today's episode with us, we will be discussing brain tumors, discussing a whole lot of things that affect people with brain tumors in Nigeria. And on today's episode, we have the distinguished consultant neurosurgeon, Dr. Festus Oshupina. Thank you, sir, for being here with us
Thank
today.
you, David and Ayodeji, for having me.
Welcome. So it's good to have you back with us again.
Yeah, thank you.
Like my co-host rightly said, today we'll be talking about brain tumor. So, sir, let's dive into the question series. Brain tumor. What is brain tumor? We've had series of discussions about brain tumor, but I'm not sure anyone has really given a full insight of what brain tumor is all about.
Okay, all right. So thank you, everyone. And thank you for inviting me to speak on the topic, brain tumors. Because this is an educative series, I would like to break it down because I know most likely I'm not talking to neurosurgeons. I'm talking to people that want information about what brain tumor is, what they need to know about it, when they should possibly seek specialist care. And that's why I'm going to start with breaking it down like, okay, when you say brain is what is inside the skull, okay? And when you say tumor, in that word, it means a new growth. So when you say somebody has a brain tumor, it simply means that the person has a new growth inside the brain. Okay? So this new growth, is it primarily coming from the tissue that are native to the brain, or is coming from other tissue from different part of the body and moving into the brain? Is now what will now bring us to say maybe you have what we call a primary brain tumor, in which the new growth is from the tissues that are native to the brain, or you have a secondary brain tumor in which the tissue that is growing into the brain is coming from extra brain or extra cranial tissue. I'm trying as much as possible to use terminologies that our viewers and listeners will be able to understand very well. Okay, so brain tumors simply means new growth in the brain. Okay, so is it coming from tissues native to the brain, or is it coming from other tissues in the body? will now be what will tell us whether this is primary or secondary brain tumor.
Thank you very much, sir. Talking about primary and secondary brain tumor, can you please differentiate between a primary or a secondary brain tumor, sir?
Okay, so just like what I've said, the tissues of the brain, what we call the neurons and the supporting cells of the brain. So you talk about the glial cells, which they have different names that we call them. So any of these people, any of this set of cells or tissues, they can lose control over their growth. When we say something has lost control, like there is a regulatory body, just like when you have regulatory system in governments and in organization. Also in brain, those different cells, either the primary neuronal cells or the supporting cells, they have regulatory system that tells them this is the rate of growth per day. This is the rate of growth per minute. This is when you know that you manufacture a new cell and this new cell is not well formed. And then once it's not well formed, you should not allow it to pass the production stage into packaging or to send it outside. So those are things that regulate how neuronal cells and supportive cells, how they work in the brain. So when there is failure of this system, then there will be abnormal growth of brain cells, the neurons, or the supportive cells, which we call the glial cells. And once you have this loss of control over their growth, they grow excessively. They grow out of control and they become brain tumor. So when that happens, right inside the brain tissue itself, that is what you call the primary brain tumor. Okay? Now, the other thing that you have to also now think about is the one I call the secondary brain tumor. We've heard of people around us that possibly have breast cancer. Some people will have lung cancer. And then they might have been treated for this breast and lung cancer before. Maybe some of them had even had a previous surgery. Some of them must have gotten what we call chemotherapy. They've gotten radiotherapy. But 2-3 years down the line, they start complaining again of headaches or weakness on one side of their body. And then you get to do a brain scan and you see a strange tissue inside the brain. So that tissue is not native to the brain tissue. It's come maybe from a regrowth of the cancer that was previously managed in the breast or the lungs. So that you call it a secondary brain tumor because it is coming from a different organ and is going to the brain. Okay? So, and the management and the prognosis of these two types of tumors, they are actually quite different. Because from what you will have realized from my explanation, the ones that are primary to the brain, if they are benign, when you say benign, something that you can still control, something that you can still put in order, that is what we call benign. When you say it's malignant, it is something that is out of control. It's everywhere. When they say something is haywire, you can't possibly put it under control. So the primary brain tumors themselves, they can actually be malignant or benign. And when you have a benign brain tumor, then cure is possible. Okay? But you have a malignant brain tumor, the risk of recurrence is high. However, all secondary brain tumors, they are, of course, malignant. Because it simply means that the tumor has left the primary place where it was previously diagnosed and managed and had moved through the body system, had gone through the bloodstream, and had broken the barriers. Like you want to enter Dodan barracks. You are going to see barriers of soldiers, trying to prevent you from entering. So by the time a tumor is moving from the breast or the lungs and is entering into the brain, it has capacity already to destroy all the security architecture that prevents foreign tissue from entering into the brain. So it simply means that tumor is already what? Malignant. And then the outlook, the outcome, and the prognosis of secondary brain tumor is not good. most of the time. Okay? Yeah. So I hope with my explanation you could understand that there is actually a whole lot of difference between a primary brain tumor and secondary brain tumor, because the primary brain tumor can either be benign or malignant, or the secondary brain tumor, they are actually almost always malignant. Okay.
All right, sir. Still speaking on the topic of clinical manifestation. I'm sure the listeners and viewers at home would like to know how does one know a person has brain tumor? For instance, now there'll be family members of people that should have been diagnosed earlier. How do they know that this person has a brain tumor or this person is at risk of having brain tumors, whether primary, whether secondary, whether benign, whether malignant? How does one know? What are the symptoms that present initially?
Yeah, well, thank you. That's you see, that's an essential part of this educative podcast, because in management of brain tumors, early presentation is key to good outcome. Okay, because by the time a patient presents to the hospital late, most likely the tumor has grown beyond the boundaries and margin of safety, has now involved other structures, adjacent structures, that will now make it very difficult to actually be able to remove all the tumors safely and have good margin of resection. Okay, so knowing the early symptoms, when to present, where to present, they are essential parts of management of brain tumors. You know, unfortunately, some of the symptoms of brain tumors can be mimicked by so many other things. so, so it makes it difficult for you not to continue treating malaria recurrently when
And it's actually brain tumor.
Yeah, when it's actually brain tumor. Because for people that have malaria, they tend to have headaches, right? Headaches, recurrent headaches in different parts of the coming up, and some of them will have fever. But of course, because we as Nigerians, we know how to go to get what we call over-the-counter drugs a lot. So even they will have some fever, but they've gone to the pharmacy, they've bought paracetamol, they've used some antipyretics, fever is down, but the headache is recurrent. But we easily think that it's the malaria that has not been fully treated. Okay. Some people will even think that this could be typhoid. By the time they finish treating malaria and the malaria headache is still persistent, they say, okay, let's go and treat typhoid. When typhoid is not there, they say, let's go and treat another infection. And then on and on, somebody that should have presented to the hospital because of recurrent, disturbing headaches had not come to see us. So the person is coming to see us 3, 4, 5, 6, 7, 8 months after, and somebody has been treating malaria, typhoid for the last 7 months. Which type of malaria will you treat consistently for 6 to 7 months? So one of the major way of presenting is actually headaches, recurrent headaches. But we have to also be specific when we are explaining it to our viewers and listeners, the characteristics of some of the headaches that patients have, especially when they have brain tumors. These are headaches that we also tell our doctors and students that these are headaches that come on more often early in the morning. And there are explanations why that is so. So headaches come on more in the morning. Patient can give a severity scale of about 8 or 9 over 10. But with time and with activity during the day, the headache tends to come down. But very early in the morning, when you think you have rested well from your sleep, then you are waking up with a very terrible headache. Then you need to see a specialist. That is one. Again, just like I mentioned the other time, brain tumor is a new growth inside the skull, inside the brain cavity and all the rest. So it's definitely going to put pressure on some parts of the brain. Putting pressure on some part of the brain is what will both give the headaches and, of course, stretching some of the coverings of the brain. And two, also it's going to put pressure on some neuronal bundles inside the brain, bundles of neurons that are sending instructions to different parts of your body. And when you tend to have this, patient can come with some subtle weakness. You can hold your biro and write very well before, then you suddenly discover that your handwriting is not regular again. because it feels weak to carry your right side of the body. They complain in your bank that your signature is not regular, and they're asking you to sign repeatedly. So, and at the same time you are having some of this, you have headaches in one side of your body that is actually disturbing you. That is weakness of one part of the body. That is something that should stimulate you to say, I got to see a specialist. Or you suddenly discover that your hands jerks and move involuntarily, and then you don't have a control over it, which is a form of focus seizure. The hand moves by itself. You want to stop it, it's not stopping. Or even somebody just wakes up, and then an adult 42-year-old had never had seizure before all his life, and then just woke up but has been complaining of headaches to the relatives and member of family, and then woke up one day and start jacking. Full seizure, generalized tonic-clonic seizure. Such things will stimulate you to think that this person could actually be having a brain tumor. Okay, so like I've said the patient can come with you with headaches which are known to be recurrent, and they are worse in the money. They can have weakness on one side of the body. Somebody can have a focus seizure. If the patient is not getting intervention on time, some of them will start vomiting, okay, from the pressure that the new growth is putting on the brain. They start vomiting, recurrent vomiting, headache, weakness. Those are general symptoms, that could occur either because of brain tumor and some other things that we may end up discussing in the course of this conversation. There are some specific things that the patient can also present with, depending on the region of the brain where the tumor is located. You see, there are different parts of our senses. You have the eyes, you have the ears, you use this to hear, you use this to see, you have your nose that you use to smell. Funny enough, you see, I've had patients before that the reason why they had come to hospital to see me and we made the diagnosis of brain tumor was because she was recurrently burning the husband's food. Anytime she's cooking in the kitchen,
It's funny.
the food will have gotten burnt and she won't know. So somebody will have to call her attention that your food is getting burnt in the kitchen.
Is it the sense of smell or the sense of sight?
The sense of smell. You see, because the tumor was arising from the base of the brain in front, around the nerves that are supposed to be responsible for the sense of smell, what we call the olfactory tract. So the lady had an olfactory groove meningioma, So meaning that the different special senses of the body could be affected by tumor, and patient could present like that. And somebody can be saying, no, it is just recurrent catarrh that she's having. That's why she could not smell and she was burning food. And she keeps seeing my colleagues in the ENT recurrently, whereas the tumor that is growing, because this person is likely to also have headaches. Some people also present with abnormal behavior.
Such as?
Yeah, somebody that can talk to you and reason with you, somebody that is naturally reserved before, does not talk to anybody, does not interact much, is someone that you will call an introvert, and all of a sudden, you discover that he plays with everybody. Because you are Mr. Ayorinde, I've not seen you in the last 4 years, I've not seen you in the last 3 years, and you keep wondering that, what suddenly changed? For 35, 40 years of your life, you have been a calm, reserved, introverted person, but now suddenly you start talking excessively. Yeah, there may be a tumor that is compressing on the frontal lobe, which may also affect the sense of smell at the same time. And that person is also at the same time talking to you that, I'm having recurrent headaches, but somebody thinks it's a psychiatric problem.
I was going to say that might be a psychiatric problem.
Yeah, because again, from our experience, we've discovered that there are so many psychiatric patients also that have been in psychiatric hospital that they actually have a brain tumor that is making them to behave abnormally. So our colleagues are doing a fantastic job in the psychiatric care. So most of them now, when they see some of these patients with this kind of strange symptoms, they tend to ask for a brain MRI. But you see, for a long time, people will think that this is just a mad person. Nah. It's just a brain tumor somewhere that is causing compressions on the frontal lobe and this person is having a headache. So we really need to ensure that we have high index of suspicion, and we should always be ready to see a specialist when your patient is having some of the symptoms. So I've been able to talk to us about sense of smell and the attitude of this person changing. Some people won't see. You just discover that you cannot see to your sides. When you look straight, you should see hands coming from your side by looking straight, but you discover that side of your vision is no longer there. Because the nerves that pick images and instruction from your eyeball, they pass at the center of your brain where a particular organ is located. We call the organ the pituitary gland. Okay. Sometimes the pituitary gland also get enlarged, rapidly enlarged, slowly enlarged, and then it compress on the nerves. And then the person finds it difficult to start seeing. Some people they come to me in the clinic totally blind from pituitary tumor. Because over the years, they've discovered that they're not seeing well, and they've been going to the ophthalmologist. They've been using different types of eye drops. They discover that the vision is becoming poorer and poorer and poorer. So at this point, you need to scan your brain. You need to scan your brain and see a neurosurgeon. Some people, what you see about them is that inability to walk. When you have an adult that has been running, you played football when you were in secondary school, you're possibly number 11, right? Or number 7, you can use both right and left leg to dribble, and all of a sudden you're finding it difficult to even move your steps. And anytime you attempt to move, you try to fall to one side or to the other side. Gait problems. Gait problems are also part of what patients with brain tumor can present with, especially when it's compressing along the tracts of the brain, especially those ones that we call the tumors that are located in the posterior fossa, compressing on the cerebellum or the brain stem. All those can come with gait abnormality. Some of them will come with hearing impairment. I've seen a patient that had meningioma before that could not hear anything. And after we removed the tumor, the patient started hearing us talking, So those are some of the things that we should look out for. So when you have a relative, a brother, a sibling, somebody that that possibly have some of these symptoms, you should know that it is not malaria, right? And not all blindness or difficulty seeing is also as a result of what we call ocular problems. So those are some of the present. There are many, but because of our time, I will just possibly be able to tell us those few. Okay.
Thank you very much, sir. So safe to say, brain tumor can affect any part of your body, any organ of your body connected to the brain.
Sure, because you get all the instructions from the brain. So there has been this argument that which is superior, your heart or the brain. I'm sure some of my cardiologist friends watching will say, nah, it's the heart. But you see, the brain also sends instruction to the heart to function. So maybe we'll put them on the same pedestal.
Okay, now my next question, what we've heard, maybe true, maybe false. I think that's the reason why we're here. Why is it that some brain tumors take longer than expected to present themselves as brain tumors, while some are swift to present themselves as brain tumors?
Fantastic question, and you see, this is one of the things we think our listeners should actually listen to very well, because it also helps us as surgeons, as neurosurgeons, to decide the course of care and possible diagnosis of such patients. Some brain tumors are very slow growing. Like when some patients come to me, I tell them, I say, fine, you are just having these symptoms now, or you are just having these symptoms just about 6 months or 1 year ago, but the tumor has been growing there for the past 15 years.
Wow.
Because they can be very slow growing. And those are the ones that we call the benign brain tumors. Tumors growing from the coverings of the brain, like meningioma. Benign tumors of the pituitary gland, like pituitary macroadenoma. We have new names that we call them now, pituitary neuroendocrine tumors, we call them PNETs. So those are slow growing tumors. So their symptoms tend to come in gradually. And you see, maybe by the virtue of our descent or the virtue of the sites that the way we take healthcare in this part of the world, when you have symptoms that are possibly not incapacitating you, people don't tend to go to hospital to say, let's get it, whether there is a way to know this is a major thing, this is a bad thing, this is something that should be attended to as soon as possible. Okay, so benign tumors, they tend to present slowly. You will see the evolution of symptoms gradually, but there are malignant problems. There are tumors in the brain that grow rapidly within 2 months, less than 2 months. High-grade gliomas. Okay, so I mentioned earlier that tumors can come either from the covering of the brain, from the neurons themselves, or from the supporting cells that we call the glial cells. Okay, so when some of these tumors have the malignant type of tumors, the glial cells, it can present within 2 months from beginning, rapidly growing, increase in size, put massive pressure in the brain, make it difficult for the person to cope with life, and such patients tend to present early because of the rapid evolution of symptoms. However, most of them are very terrible tumors to deal with. And like I always tell my patients that some of my patients with GBM, glioblastoma, I tell them, is one of the worst disease, of mankind, in terms of both the rapidity of evolution, both the rapidity of recurrence, and the final outcome of care. So, sure, some patients will present early, some patients will present late, and those are factors of, are we dealing with a benign or malignant brain tumors?
All right, sir. Bringing you back to what you said on behavioral changes when these sorts of situations present. Are there any form of activities that we engage in, perhaps like stress, lifestyle changes? Are there any things that we do that put us within the risk of having brain tumors?
Yeah, I'm happy with the fantastic questions you're asking, because anytime you sit in the consulting room, and I sit behind my table, and one way or the other, we have a patient that possibly has a brain tumor and I'm counseling them. One of the questions that will definitely follow is, what caused it? What are the risks? You see, because you don't talk about tumors when you don't know what are the possible things that are causing it, and then you don't talk about prevention when you don't know what to prevent. Okay, so brain tumors are often multifactorial, and when you say multifactorial, you talk about the environmental, the genetic component, the hereditary components. To say that all of those things, they interplay together to expose people to development of brain tumor. However, you need to know that some patients that you make diagnosis of brain tumor in, they are possibly not exposed to any risk at all before. They are possibly not having any family history or genetic predisposition. And what has happened to them are things we call sporadic mutations. Like I explained to you, your body is like a factory. People that are making bottled water, you possibly make the bottle, you fill it with water. I'm sure somebody is going to assess whether the water is well filled up or not, the quality control, and then somebody will possibly cover it up, and then they will check whether it's well covered before it's moved to carton. The same thing happens in your body. Daily, your body cells, they also grow old as you grow old. And when they grow, they divide with their chromosomes and their genetic components. Every time those divisions happen, there are tendencies for mistake to happen. When you are supposed to divide them into 23 equal halves, there are tendencies that there will be 24 on one side and there will be 22 on one side. So the same thing that happens in production. And when such things happen, but there are systems, just like the quality control in productions, that will stop the production at that level and say, no, this is 24, this is 22. We take the extra one here and put it where 22 so that it can be completed. Okay, so if that happened, then you are able to correct the problem that can lead to development of tumor down the line or an abnormality. because that single moving of one extra chromosome or genetic material from one cell, like a mother is divided into two, and this now has 24, this has 22, can give this one a power of immortality. When you say power of immortality, it cannot make it grow uncontrollably, that nobody can talk to it again, and it becomes a tumor. So there are systems in the body that we attempt first to take this extra one and return it to where it's supposed to be. So, but if this particular 24 guy is now very notorious and is refusing to release that extra one, there is another level of system that will say, if you are not allowing me to return it to the proper place, then I'll kill you.
Okay.
So that there is another system that wants to kill this 24. So if the system now succeeds to kill it, there is no tumor. But if we again now try as much as possible to escape the gentleman that wants to kill it off, and then he's supposed to go out through a door. So if he kills the gentleman at the gate, then he escapes, then it becomes totally malignant. So that explanation tells you that somebody may actually not have a family history of brain tumor, may not be exposed to an environmental factor, but can still develop brain tumor. How? By sporadic mutation, which is what I just explained. Now, are there environmental factors, things that you get exposed to every day that can increase your risk of developing brain tumor? Absolutely, yes. People that have trauma, previous traumatic brain injury, hit their head against things, they can injure the covering of the brain. And the covering of the brain, sometimes when it is trying to heal itself, it can also have the problems of developing some sort of brain tumors. So other environmental risk factors, including behavioral factors, excessive alcohol intake, excessive smoking or smoking generally, they are known to be risk factors for development of tumors, excessive alcohol intake. Now, some pesticides, insecticides, people that work on the farm and on industrial areas, and that is why it's always advisable that when you know that you are exposed to some particular chemicals in the industry where you're working, you use a face mask, because some of those industrial chemicals can actually go and initiate changes in the genetic composition of the cells and make them to become immortal, and then they become malignant and they can change to brain tumors. Sometimes you also talk about patients having infection. There are some particular infections that when it comes into the system can also do the same thing, can initiate the same process that I explained earlier on, and then subsequently expose the patient to develop brain tumors or tumors generally. So that is talking about the environmental factor. Now, there are possible familial hereditary risk factors. Patients that they have family history of tumors, colorectal tumors, breast cancers, and all the rest, or a previous family history of brain tumors. Those are some of the risk factors that can make somebody to develop brain tumors. So, and when somebody or a patient has some of the symptoms that we have discussed earlier, and then has been particularly exposed either to some of these environmental risk factors that we discussed, or has a family history of brain tumor, that person should come to the hospital and present early to see a specialist, because early presentation often comes with good outcome in care of brain tumor.
Thank you very much, sir. My next question, are brain tumors age-related, or are there particular age ranges that are at higher risk of getting brain tumors?
Good question. Yeah, brain tumor can occur in all ages. However, the types of brain tumor that a person is going to have is most time related to the age group. Like when I said anybody can have a brain tumor, I've seen a child that is less than 1 year with brain tumor. And I've seen 80-something-year-old patient with brain tumor. There are also what we call congenital brain tumors. Brain tumors that patients are born with. But the distribution of these brain tumors, where they occur in the brain, how they occur, they are different. So that somebody is 10-year-old does not mean that the cause of the headache cannot be brain tumor. I've had patients that are quite young, and I've had patients that are quite old presenting. It's just that the area, like for example, even though we've reported cases of meningioma in pediatric patients, but meningiomas are more common in females and in fourth, fifth, sixth decade of life, because they come up from the coverings of the brain. There are gliomas that can be primary or secondary glioma, like high-grade gliomas. Some of them will start as benign, and then they metamorphosize and then become malignant. So the age range, anybody can have brain tumor. So the more reason why you will not say, no, if you are having these symptoms, it is not brain tumor. It is not brain tumor. Your age does not permit it. No, it can be brain tumor. But the type of brain tumor that the person has in a particular age group bracket, they are actually different. So I think that would be the answer I'll give to the question.
All right. Now we are going to be moving over to the surgery aspect of these things now. People usually used to say, brain tumor, the surgery can be quite risky, can be quite. Is that still the case with modern neurosurgery? In your vast experience and opinion, is that still the case with modern neurosurgery?
Yeah, you see, the practice of neurosurgery has evolved. But you see, every single surgery have possible attendant complications and risk. So what the modern neurosurgery has done for us is to reduce the possibilities of having these complications because of the availability of better skill sets and better safety equipment. However, the diagnosis of a brain tumor is not what is comfortable with any patient relative, or healthcare provider. So, but the care of neurosurgery, the care of brain tumor is actually much better in the country. Now, bringing it home now to the perspective of Nigerians, care that we have for brain tumor now is much better. I remember I told one of my patients some years ago, maybe like a year or two, that when we started training for neurosurgery, long before then, there used to be surgeries that you will do for 14, 15 hours, and you may actually not be able to remove the whole of the tumor. Not because that the skill is not available, but because of the kind of equipment they were available at the time. But that same tumor now that you possibly need to crack the brain, the skull of the patient open for them, and have to be removing the tumor one after the other, spend 14, 15 hours, prolonging the exposure of the patient to anesthesia. That kind of surgery now can be done through the nose under 2 to 3 hours and remove much, much more tumor, if not everything, rather than what we were doing for 14 years before. So 14 years, 14 hours?
Technology has evolved.
Technology has evolved. Availability of more equipment, more trainings, more exposures, and more skills. So care of brain tumors in Nigeria has really evolved. And we are proud to say that we are part of the team and the group of people that are leading this evolution. I'm sure that there are a lot of equipment available in different hospitals across the country now, and Dukes is actually trying to ensure that we lead the pack in this once it comes to neuroscience and neurosurgery. People now make use of HD endoscope, 4K endoscopes to remove brain tumor through the nose. We are very known for that in Dukes, that with pituitary tumors, some of the posterior anterior cranial fossa tumors. We try as much as possible to do that through the help of endoscopes with our team. There are also better equipment that enhance visibility. Operating microscopes will definitely help you to be able to differentiate between structures that you are not supposed to touch and the ones that are safe to be removed. So availability of operating microscope is one of the things that has also helped our practice in most of the hospitals around and also in Duke's neurosurgery. And then, of course, our neurosurgeons are well trained, both local and international exposure, and well grounded in the skills of neurosurgery. So those are some of the things that now make the modern care of brain tumor more fascinating. But however, like I mentioned in the beginning of this discussion, early presentation is the way to go. Because even with all our available gadgets and everything and the skills, if a patient is presenting to us so late with involvement of all the vital adjacent structures, you don't want to sacrifice the vital adjacent structures while you are trying to remove the brain tumor. So there is a slogan that I will always tell my patient. Removing brain tumor means that we want to do what we call maximum safe resection. Okay? We want to remove this brain tumor as much as possible, but our resection must be safe in the sense that you must come to us and we should be happy to bring you out of the theater alive after removing the brain tumor. And that's been the slogan, and that's been our practice, and that's been the principle behind the push that we have seen and we know in Duke's neurosurgery.
All right, thank you so much.
So, sir, are all brain tumors removed through surgeries, or is there any other safe treatment plan to manage brain tumors aside surgery?
Good question. It is not all brain tumors that should be operated. Because if somebody has a brain tumor that is not symptomatic, a brain tumor that is possibly less than 3 millimeters in size, that is just an incidental finding. Because there are some brain tumors that are actually incidental findings. Maybe when you are investigating the patient for other things, other complaints that they have come with, then you discover that on your brain MRI, you see a tiny brain tumor, maybe just less than 3 centimeters or thereabout in one location, not causing pressure, not causing anything on the brain. That is not when you are now going to say you've seen somebody to operate and then you want to go and crack the skull open. Now, the patient is not symptomatic. There is no compression on any adjacent structures, no compression on any neurons. So what we do in that case is that you are going to monitor the tumor radiologically. You can put your patient to see every 6 months, every 1 year. I want to do a brain scan to monitor the size of the tumor. Sometimes when you have patients like that, some people prescribe what we call stereotactic radiosurgery. Like gamma knife. You want to expose that tiny tumor to high intensity ray of light, such that it can reduce the size, or what we say it controls the growth of the tumor. That's the essence of it. It's different from radiotherapy that we commonly know and have around in Nigeria. As of today, I don't think there is stereotactic radiosurgery available in Nigeria, and it's one of those things that Dukes is hoping to bring into the country as soon as we are able to do that. Because not all tumors should be operated. Sometimes you just need to expose them to high intensity radiation. The stereotactic radiosurgery is supposed to be a specific target, minimizing the effect of this high intensity radiation to adjacent structures, which, unlike what you have in radiotherapy, the conventional radiotherapy, in which you shine the high intensity light both to the abnormal structure and to the normal brain tissues around it. And of course, patient is definitely going to come down with some sort of a complication at that. So I've told you, not all brain tumor should be operated. Some of them, you do what we call watchful waiting and monitor the size at the increase. Some, you do what we call stereotactic radiosurgery to control the growth of the tumor. But if a patient is having any of the symptoms that we have discussed earlier and is having some neurological deficit, that kind of patient should have a good discussion with his or her specialist, and we should now be able to reach a conclusion on the options of care available. Now, also, to just add to the answers, is that not all, you don't treat, it is not, what can I say now? It's not only one caps fit it all, you know. Treatment of brain tumor, it depends on the histological diagnosis of the tumor by the time you remove from this tumor and send it to the lab. And then we also now do immunochemistry and genetic testing for most of this tumor now to be able to cone down specifically on what type of tumor it is. Because that is also going to inform your decision on other adjuvant therapies or adjuvant care that you can use for this patient. For example, I've mentioned radiotherapy. Some brain tumors also respond to chemotherapies, especially for the chemotherapeutic drugs that can penetrate through the blood-brain barrier, you know. So those are things that I think I will need to tell you. Watchful waiting, stereotactic radiosurgery, surgery itself, and then the adjuvant care, which could be chemotherapy or radiotherapy. And funny enough, all these are available in the country. So Nigeria is not where it was 10, 15, 20 years ago. Maybe except stereotactic radiosurgery, and hopefully that should also be available in the country as soon as possible.
All right, sir. That was a very, very insightful answer, and he shed more light on the question that he asked. And moving on, I would like to ask on behalf of our listeners, our viewers, somebody they know might have a brain tumor diagnosis. What's the realistic piece of advice you can give to them watching this currently?
Yeah, like brain tumor diagnosis is not a pleasant news. Okay, nobody hears such news and go back to bed and sleep nicely. And maybe somebody sends you a message in the following morning and say, "How was your night?" And you say the night was good. No, but however, the cure and the care of brain tumor is available in the country. So early presentation is key. Now, one of the problems we have with our people in this part of the world is that when you get to see your doctor finally, and they say that, oh, this is the diagnosis, they show you on the screen and say this is where the brain tumor is, this brain tumor needs to be removed. That patient may leave that consulting room and not return in another 8 months. By the time you are returning to your specialist, the tumor had multiplied in size. So please, anytime you have a relative, you have a sibling, you have a friend, and the diagnosis is that of brain tumor, follow up with the care. Okay? Once the diagnosis is made, ask for the next phase of things. You see, some years ago, there was a gentleman that was working with a government agency, and he discovered that every time that he gets to work, he will just faint, jerks and faint. He was having generalized tonic-clonic seizure. Then they took him to a particular hospital and they told him what he had was a brain tumor. Then he left the hospital and went somewhere to go and be doing some sort of looking for cure, not in the hospital setting, and was there for 4 years. But nothing happened. Right where he was trying to look for care, he keeps having this recurrent seizure. He kept having the recurrent seizure. He kept having it. He kept having it, falling down, doing whatever, falling down, doing whatever. So one day, one of his relatives went to go and kidnap him from where he went to and brought him to the hospital. Huge olfactory groove meningioma. had his surgery, tumor was removed, back to his normal life.
And his sense is restored.
Yeah. After wasting 5 years. 5 good years. Of course, the tumor became bigger by the time we were seeing, but lucky chap, surgery was done, he was fine, things were good, went back to his normal life. So that emphasizes the fact that once you make a diagnosis of brain tumor, even though it is not a convenient diagnosis to make, try as much as possible to follow up with the care. Your doctor will likely ask you, if you have not done MRI before, that you should do a brain MRI. Get the brain MRI done, bring it to him. He'll possibly ask you to do a few other tests. For example, if it is a pituitary tumor, he'll possibly ask you to do what we call a hormone profile. He'll possibly ask for ophthalmological evaluation of the functions of your eye. He'll possibly want to check other parts of the body if he's suspecting that this could be a metastasis to the brain. So you want to check the chest, you want to check the abdomen, you want to be sure whether you are fit for surgery or for anesthesia by checking the functions of your heart and all the rest. Those are some of the steps and stages you're going to have to go through. And after which, you can now decide to say, oh, you're fit for surgery, and then you should have surgery done. The advice I'm going to give again is the fact that try as much as possible to have the surgery done in a safe, secure environment, because post-op care is also very important to you. And I must say that Duke's Neurosurgery is very big on post-op care management, because this is what we do. This is our core area of specialty. We are center of excellence for neuroscience. So as much as possible, every single member of staff that work in the system, they possibly manage a lot of patients in the post-op state for neurosurgery, for brain surgery, for spine surgery, for neuroscience related problems before. Okay, so those are some of the pieces of advice that I'm going to give to my patient.
All right, sir. Thank you so much for that question. And do you have anything to...
So, final question from me. From your vast experience as a neurosurgeon, what are some of the myths that you have to daily correct when you see your patients who come in for brain tumor related issues?
It's an arrow. It's an arrow now. It's a family arrow. It is somebody that does not like me in my village that sent it to me. Oh, of course, I'm not saying that there is no arrow. There could be arrows, there could be spear, there could be rods, but you see, the diagnosis of neurosurgery is there. So, and then when I talk to my patient, I tell them, I'm talking to you as a scientist. I'm not talking to you as a religious leader or as a tribe leader. I'm talking as a scientist now. I know that this is what I know that is the cause of brain tumor. Well, one thing you are going to find out is, it's an arrow. It's somebody that doesn't like me, that doesn't want me for good. So you see that common. Okay, so maybe the other things you are going to be like, oh, I don't believe. They live in denial. So I see about people that said, no, I don't want to do it, it's going to disappear. I do not say miracle doesn't happen, but those are things that I encounter in the consulting rooms, And again, I also experience a lot of times that people possibly have even been managed for other things. And then when they are now faced with the reality of all those other things they are managing you for are possibly not the cause of your problem. This is the cause of your problem. Then it becomes difficult for them to even believe you, because out of 5 people that they have seen, you are the only one telling them what is different. And that is why, you see, you need to always try to see a specialist. You see, I'm not negating the fact that brain tumors have differentials. And I'm not sure whether I've mentioned a lot of them, We've had patients that people think it was stroke. 2022, I think November or October, I just received a call late in the night and somebody told me that somebody had a stroke. And then they are bringing him to the hospital. I said, okay, stroke. So how did it happen? The doctor on the other side of the phone explained to me this and this and that. So in my mind immediately, I processed that this is not a stroke. It doesn't sound like a stroke. But of course, for most of our people here, once there is weakness on one side of the body, difficulty to speak, facial droop, we think, oh, a stroke. So I saw the patient, interacted with the patient, and I said, no, this is not stroke. So we looked at the brain scan. It was a brain tumor. Remove the brain tumor. Patient is living his life till today. So again, those are some of the confounding factors and things that we see in the consulting room. Somebody that has been managed for stroke recurrently and they kept saying it's not improving. Then you view the patient yourself and look at the scan and you see a brain tumor. So some infections also could be in the brain and we will mimic like brain tumor, abscesses, subdural abscesses, epidural abscesses, even intracerebral abscesses. When they are there, they also put pressure on the brain and they look like brain tumor. But their care is a bit slightly different. Okay? So those are some of the things, and of course, not like everybody that you now see on the street that is complaining of headache is having brain tumor. That's not what this podcast has been about. Because some people also will have migraine.
Yes.
Okay? There are other things that can, even stress, economic stress can give headaches. So there are other things that can give headaches. But you see, we've been able to talk about the characteristic of the headaches we are looking for. It's a recurrent headache. It's not a one-shot headache. It's been there. It's possibly worse in the morning, and it gets relieved as your activity goes on. Those ones are more in fitting to say that this person is having a brain tumor. So those are some of the myths. Those are some of the confounding factors. Refusal of patients to continue with care. Difficulty to believe that this is not an arrow. That this is actually science coming into play. But we hope with this kind of health education, with this kind of discussion we'll keep having, we're sure that one way or the other, we will be able to get our viewers and our patients to understand that early diagnosis, early presentation, early diagnosis, they are things that are essential to good outcome.
All right, sir. Thank you so much for dissecting this very, very intimate topic of brain tumors. And thank you so much for gracing us with your presence on this episode. We happen to have learned a lot. I'm sure those of you listening and watching from home, I'm sure you learned a lot on brain tumors. Thank you so much, and God bless you.
So our viewers and listeners at home, once again, we hope you've learned one or two things through this health conversation with Dukes. What you can do is subscribe, like, share, reshare this, let your family members learn, let them see what we're doing here. We'll see you when next we'll come again on this beautiful podcast. Thank you. Love you.